పవర్ పాయింట్ ఉంది పెట్టుకోండి ఆన్ చేసుకోవచ్చు ఆల్రెడీ స్టార్టింగ్ అయిపోయింది జస్ట్ పవర్ పాయింట్ ఓపెన్ సరిపోతుంది
ఒకసారి
ఆల్రెడీ స్క్రీనింగ్ స్టార్ట్
ఉండండి.
నేను ముఖం తీసుకుని మాట్లాడవచ్చు.
ఓకే, good morning everyone. Today we are going to discuss reproductive system. In last classes we have covered thyroid disorders. So in this class we will see reproductive system and common presenting problems of reproductive disorders. Coming first to functional anatomy, physiology and investigations. In male, the testis serves two principal functions, that is synthesis of testosterone by interstitial Leydig cells. It is under the control of LH, and spermatogenesis by Sertoli cells, which is under the control of FSH, as well as testosterone. Negative feedback suppression of LH is mediated principally by testosterone, whereas FSH is inhibited by inhibin. The axis can be assessed easily by a random blood sample for testosterone, LH and FSH. Testosterone levels are higher in the morning, and therefore if testosterone is marginally low, then the sampling should be done at morning 9 o'clock. Testosterone is largely bound in plasma to sex hormone binding globulin. This can also be measured to calculate free androgen index or bioavailable testosterone. Whereas testosterone is bound to SHBG, that is sex hormone binding globulin, which is not bound to globulin, is free, that is bioavailable testosterone. Testicular function can also be tested by semen analysis. There is no equivalent of menopause in men, although testosterone concentration decline as age increases and from fourth decade onwards. In this figure, this shows what we have discussed in the previous slides, that is pituitary gonadotropes produce LH, which acts on interstitial Leydig cells to produce testosterone. Testosterone along with the FSH produced from the gonadotropes of the anterior pituitary act on the Sertoli cells, which is useful in the spermatogenesis, and Sertoli cells also produce inhibin, which has a negative feedback on FSH. Testosterone has a negative feedback on LH. Testosterone is useful for facial, axillary and body hair growth, and it is responsible for scalp balding and skin sebum production and penis and scrotal development, prostate development and its function, and laryngeal enlargement, and it is also responsible for muscle power and bone metabolism or epiphyseal closure. It is responsible for libido as well as aggression in males. Female. The female physiology varies during the normal menstrual cycle. That is, FSH stimulates growth and development of ovarian follicles during the first 14 days after menses. This leads to FSH acting on the ovarian follicle. This leads to gradual increase in estradiol production from granulosa cells, which initially suppress FSH. That is, initially it has negative feedback on FSH. Above a certain level of estradiol, it stimulates or it increases GnRH secretion, resulting in marked increase in LH secretion. That is, there is a positive feedback. The mid-cycle surge of LH induces ovulation. After release of ovum, the follicle differentiates into corpus luteum, which secretes progesterone. Unless pregnancy occurs during the cycle, this corpus luteum regresses, and there is a fall in progesterone level, and there is menstrual bleeding. Circulating levels of estrogen and progesterone in premenopausal women are therefore critically dependent on time of the cycle. This figure shows what we have discussed just now. That is, pituitary gonadotropes produce LH and FSH, which acts on the ovarian follicle to produce estradiol and progesterone, and it also produces inhibin, which has negative feedback on FSH secretion. Estradiol is useful in endometrial proliferation, genital development and lubrication, breast proliferation, bone epiphyseal closure and mineral content. It is responsible for body fat distribution and skin sebum production. Progesterone is useful for endometrial secretory changes and increased myometrial contractility. It is useful in thermogenesis and breast swelling. And left side of the figure we can see the first FSH acts on the follicles. There is increase in production of estradiol. Initially there is a negative feedback on FSH. As the estradiol concentration increases, it has a positive feedback on LH, and LH increases. Increase in LH leads to ovulation. After the ovulation, there is a formation of corpus luteum. This corpus luteum is responsible for the production of progesterone. Um, if there is no fertilization, so, this corpus luteum starts to regress, and there is a fall in the progesterone level. As the progesterone level falls, there is onset of menstruation. The most useful test of ovarian function is a careful menstrual history. If menses are regular, measurement of gonadotrophins and estrogen is not necessary. In addition, ovulation can be confirmed by measuring plasma progesterone levels during luteal phase, that is day 21 progesterone. Cessation of menstruation, menopause, occurs at average age of 50 years. In the 5 years before menopause, there is increase in number of anovulatory cycles. That is referred to as climacteric. Estrogen and inhibition secretion falls, and negative feedback results, and there is fall in negative feedback. So there is increase in secretion of gonadotropins as well as LH and FSH above the level of 30 international units per liter. Coming to pathophysiology of male and female reproductive dysfunction, classification of diseases of reproductive system according to the pathophysiology, that is, it can be hormone excess or hormone deficiency or hormone hypersensitivity or hormone resistance or non-functioning tumors. In hormone excess, that is primary disorder includes the defect is in the gonads. The disorders or the diseases include polycystic ovarian syndrome, granulosa cell tumor, Leydig cell tumor, or teratoma. And secondary includes the defect in the pituitary or hypothalamus. Pituitary gonadotropinoma can cause hormone excess. And hormone deficiency, primary disorder include menopause, hypogonadism, Turner syndrome, or Klinefelter syndrome. And secondary causes of hormone deficiency include hypopituitarism, Kallmann syndrome, severe systemic illness, hormone hypersensitivity. Primary disorder include idiopathic hirsutism. Hormone resistance, primary disorder include androgen resistance, testicular feminization. Partial testicular feminization include Riefenstein syndrome or 5-alpha reductase type 2 deficiency. Non-functioning tumors include ovarian cyst, carcinoma, teratoma, or seminoma. Coming to presenting problems in reproductive disease. What are the presenting problems in reproductive disease? It includes delayed puberty, precocious puberty, amenorrhea, male hypogonadism, Okay, and there can be hirsutism or infertility or gynecomastia. These are the presenting problems. We will discuss one by one. That is first coming to delayed puberty. Puberty is considered to be delayed if onset of physical features of sexual maturation has not occurred by chronological age, that is 2.5 standard deviations above national average. That is, if there are no signs of puberty by the age of 14 in boys or 13 in girls, then we can call it as delayed puberty. Genetic factors have a major influence in determining the onset of puberty. It is also influenced by nutritional status and chronic illness. Coming to clinical assessment, first seeing the causes of uh, delayed puberty and hypogonadism. It can be due to constitutional delay or hypogonadotrophic hypogonadism or hypergonadotrophic hypogonadism. Hypogonadotrophic hypogonadism, the defect is in the hypothalamus or pituitary. That is structural hypothalamic or pituitary disease. Functional gonadotrophin deficiency occurs in systemic illness or psychological stress or anorexia nervosa or hyperprolactinemia, excessive physical exercise or other endocrine disorders. Hypergonadotrophic hypogonadism, the defect is in the gonads. It can be acquired or developmental. Acquired gonadal damage can be due to chemotherapy or radiotherapy or surgery to gonads or trauma to gonads or autoimmune gonadal failure. It can be mumps or itis or tuberculosis affecting gonads and hemochromatosis. Developmental disorders of gonads include steroid biosynthetic defects, or Klinefelter syndrome, or Turner syndrome. The key issue is to determine in delayed puberty is whether the delayed puberty is simply because the clock is running slow, that is, that constitutional delay of puberty, or because there is a pathology in hypothalamus or pituitary, hypogonadotrophic hypogonadism, or the defect is in the gonads, hypergonadotrophic hypogonadism. A general history and physical examination should be performed with particular reference to previous or current medical disorders, social circumstances, and as well as family history. Body proportions, a sense of smell, and pubertal stage should be carefully documented in boys. Presence or absence of testis and scrotum is noted. And current weight, height may be plotted on centile charts. Coming to constitutional delay of puberty, that in delayed puberty we have seen three causes, that is constitutional delay of puberty, hypogonadotrophic hypogonadism, as well as hypergonadotrophic hypogonadism. Constitutional delay of puberty, this is the most common cause of delayed puberty, but is much more frequent explanation for lack of pubertal development in boys than in girls. That is, constitutional delay of puberty is most common in boys than in girls. Affected children are healthy and usually have been more than 2 standard deviations below the mean height for their age throughout childhood. There is often history of delayed puberty in siblings or parents. Sex steroids are essential for fusion of epiphysis. Bone age can be estimated by X-ray of epiphysis, usually of wrist and hand. In constitutional delay, bone age is lower than chronological age. Constitutional delay of puberty should be considered as normal variant, and puberty will come in spontaneously. Hypogonadotrophic hypogonadism. This may be due to structural, inflammatory, or infiltrative disorders. Just now we have seen in the previous slide causes of hypogonadotrophic hypogonadism. That is, the defect is in the pituitary or hypothalamus. It can be structural or functional. In hypogonadotrophic hypogonadism, there is other pituitary hormone deficiency also, such as high growth hormone. Functional gonadotrophin deficiency is caused by a variety of factors, that is chronic systemic illness or endocrine disorders or profound psychosocial stress. Isolated gonadotrophin deficiency is usually due to genetic abnormality that affects the synthesis of either GnRH or gonadotropins. Most common is Kallmann syndrome. in which there is primary GnRH deficiency, and in most affected individuals, there's the agenesis or hypoplasia of olfactory bulbs. Uh, as there is involvement of olfactory bulbs, there is hyposmia or anosmia. If isolated gonadotropin deficiency is left untreated, the epiphyses fail to fuse, resulting in tall stature with disproportionately long arms and legs relative to trunk height. That is Junacoid habitus. And cryptorchidism, undecided testes, and gynecomastia are commonly observed in all forms of hypogonadotrophic hypogonadism. Coming to hypergonadotrophic hypogonadism. Hypergonadotrophic hypogonadism associated with delayed puberty is usually due to Klinefelter syndrome or Turner syndrome. Other causes we have seen in the previous slides. Investigations, key measurements are LH, FSH, testosterone, and estradiol. Chromosome analysis should be performed if gonadotropin concentrations are elevated. That is hypergonadotrophic hypogonadism. If gonadotropin concentrations are low, then differential diagnosis lies between constitutional delay and hypogonadotrophic hypogonadism. A plain X-ray of wrist and hand may be compared with set of standard films to obtain bone age. Full blood count, renal function, liver function, thyroid function, celiac disease autoantibodies should be measured. But further tests may be unnecessary if blood tests are normal and if we are suspecting constitutional delay. If hypogonadotrophic hypogonadism is suspected, then neuroimaging and further investigations are required as there is a defect in the pituitary or hypothalamus. Coming to management, puberty can be induced using low doses of oral estrogen in girls, ethinyl estradiol 2 microgram daily, or testosterone in boys, testosterone gel or depot testosterone esters. Higher doses carry a risk of early fusion of epiphyses. In children with constitutional delay, this priming therapy can be discontinued when endogenous puberty is established. In children with hypogonadism, underlying cause should be treated. If hypogonadism is permanent, sex hormones doses are gradually increased during puberty, and full adult replacement doses are given when development is complete. This completes delayed puberty. Coming to precocious puberty. Precocious puberty is uh, early development of secondary sexual characters before the age of 9 years in boys and 8 years or 6 to 8 years of age in girls. Central precocious puberty is due to early maturation of hypothalamic pituitary gonadal axis and is gonadotropin dependent. It is more common in girls than boys, and often no structural cause is identified, that is physiological clock is running fast. Structural causes are found more commonly in younger children and in boys and include that is functional causes are common in girls and structural causes common in boys. Structural causes include CNS tumors such as astrocytoma or germ cell tumors secreting HCG, human chorionic gonadotropin, and hypothalamic hematomas. CNS injury caused by infection or inflammation or trauma or congenital CNS structural abnormalities. Pseudo or peripheral. Earlier we have seen central causes. This peripheral or pseudo precocious puberty is much less common and is due to excess sex steroids in absence of pituitary gonadotropins. Causes include congenital adrenal hyperplasia and McCune-Albright syndrome. Coming to investigations, measurement of basal and GnRH stimulated gonadotropin levels will allow categorization into central or peripheral precocious puberty, with gonadotropin levels rising in central precocious puberty. Imaging of CNS is required in cases of central precocious puberty, while adrenal and ovarian imaging is indicated in peripheral precocious puberty. That is, in central, there is defect in the pituitary, so there is imaging of CNS needed. In peripheral precocious puberty, there may be defect in the adrenal or ovarian, so the imaging of adrenal and ovaries are required. Coming to management of precocious puberty, social and psychological difficulties may accompany the onset of precocious puberty, and premature closure of epiphysis can result in reduced final height. In central precocious puberty, development can be arrested with long-acting GnRH analogs. In both central and peripheral precocious puberty, treatment of any underlying cause should be done. That completes delayed puberty and precocious puberty. Now coming to amenorrhea. What does amenorrhea? Primary amenorrhea may be diagnosed in a female who has never menstruated. This usually occurs as manifestation of delayed puberty, but may also be consequence of anatomical defects of female reproductive system, such as endometrial hypoplasia or vaginal agenesis. Secondary amenorrhea is cessation of menstruation in female who previously had periods. The cause of this common presentation are that is causes of secondary amenorrhea. It can be physiological, like in pregnancy or menopause, or it can be due to hypogonadotrophic hypogonadism, that is defect in the pituitary or hypothalamus, or ovarian dysfunction, that is hypergonadotrophic hypogonadism, or polycystic ovarian syndrome, or androgen secreting tumors, and uterine dysfunction in Asherman syndrome. In non-pregnant women, secondary amenorrhea is almost invariable consequence of either ovarian or hypothalamic or pituitary dysfunction. Premature ovarian failure, that is premature menopause, is defined arbitrarily as occurring before 40 years of age. Rarely endometrial adhesions, Asherman syndrome. What is Asherman syndrome? It can form after uterine curettage, surgery, or infections with tuberculosis or schistosomiasis, preventing endometrial proliferation and shedding. Coming to clinical assessment in amenorrhea, the underlying cause can often be suspected from associated clinical features and the patient's age. Hypothalamic or pituitary disease and premature ovarian failure result in estrogen deficiency, which causes a variety of symptoms usually associated with menopause. Symptoms of estrogen deficiency include vasomotor effects like hot flushes, sweating, psychological symptoms like anxiety, irritability, and emotional lability, and genitourinary symptoms like dyspareunia, painful coitus, or urgency of maturation or vaginal infections. A history of galactorrhea should be sought. Significant weight loss of any cause can cause amenorrhea by suppression of gonadotropins. Weight gain may suggest hypothyroidism or Cushing syndrome, or very rarely hypothalamic lesion. Hirsutism, obesity, and long-standing irregular periods suggest polycystic ovarian syndrome. The presence of other autoimmune diseases raises the possibility of autoimmune premature ovarian failure. Investigations. Pregnancy should be excluded in women of reproductive age by measuring urine or serum HCG. Serum LH, FSH, estradiol, prolactin, testosterone, T4, and TSH should be measured, and in the absence of a menstrual cycle, can be taken at any time. High concentration of LH and FSH with low normal estradiol suggests primary ovarian failure. Ovarian autoantibodies may be positive when there is an underlying autoimmune etiology, and a karyotype should be performed in younger women to exclude mosaic Turner syndrome. Elevated LH, prolactin, and testosterone levels with normal estradiol are common in PCOS. Low levels of LH, FSH, and estradiol suggest hypothalamic or pituitary disease, and pituitary MRI is indicated. There is some overlap in gonadotrophin and estrogen concentration between women with hypogonadotrophic hypogonadism and PCOS. If there is any doubt uh, whether it is PCOS or hypogonadotrophic hypogonadism, then a response to 5 days of treatment with oral progestogen, that is medroxyprogesterone acetate 10 mg twice daily, can be given and assist. In women with PCOS, progestogen will cause maturation of endometrium and menstruation will occur a few days after progestogen is stopped. In women with hypogonadotrophic hypogonadism, menstruation does not occur following progestogen withdrawal because endometrium is atrophic as a result of estrogen deficiency. If doubt persists in distinguishing estrogen deficiency from uterine abnormality, the capacity for menstruation can be tested with 1 month of treatment with cyclical estrogen and progestogen, usually administered as combined OCP, oral contraceptive pill. Assessment of bone mineral density by dual X-ray absorptiometry may be appropriate in patients with low androgen and estrogen levels. Coming to management of amenorrhea, where possible, underlying cause should be treated. For example, women with functional amenorrhea due to excessive exercise and low weight should be encouraged to reduce their exercise and regain some weight. In estrogen deficient women, replacement therapy may be necessary to treat symptoms and prevent osteoporosis. Women who have had a hysterectomy can be treated with estrogen alone, but who has uterus should be treated with combined OCP since unopposed estrogen increases risk of endometrial cancer. Cyclical hormone replacement therapy regimens typically involve giving estrogen on day 1 to 21 and progesterone on days 14 to 21 of the cycle, and this can be conveniently administered as OCPs. If estrogenic side effects are like fluid retention or weight gain or hypertension or thrombosis are present, then lower dose oral or transdermal hormone replacement therapy may be appropriate. In postmenopausal women, hormone replacement therapy have been shown to relieve menopausal symptoms and to prevent osteoporotic fractures, but is associated with adverse effects which are related to duration of therapy and patient's age. In patients with premature menopause, HRT should be continued up to age of 50 years, but continued beyond this age only if there are symptoms of estrogen deficiency. Male hypogonadism, that we have seen delayed puberty, precocious puberty, amenorrhea. Now coming to male hypogonadism. The clinical features of both hypo and hypergonadotrophic hypogonadism include loss of libido, lethargy with muscle weakness, and decreased frequency of shaving. Patients may also present with the gynecomastia, infertility, delayed puberty, osteoporosis, or anemia of chronic disease. Mild hypogonadism may also occur in older men, particularly in context of central adiposity and metabolic syndrome. The mechanisms of metabolic syndrome causing mild hypogonadism include reduction in sex hormone binding globulin by insulin resistance and reduction in GnRH and gonadotropin secretion by cytokines or estrogen released by adipose tissue. Testosterone levels also fall gradually with age in men, and this is associated with the gonadotropin levels that are low or inappropriately within normal range. There is increasing trend to measure testosterone in older men, typically as a part of assessment of erectile dysfunction and lack of libido. Coming to investigations in male hypogonadism is confirmed by demonstrating low fasting 9-hour serum testosterone level. The distinction between hypo and hypergonadotrophic hypogonadism is by measurement of random LH and FSH. Patients with hypogonadotrophic hypogonadism should be investigated for pituitary disease. Patients with hypergonadotrophic hypogonadism should have testes examined for cryptorchidism or atrophy. And a karyotype should be performed to identify Klinefelter syndrome. Coming to management, testosterone replacement is clearly indicated in younger men with significant hypogonadism to prevent osteoporosis and to restore muscle power and libido. Routes of testosterone administration can be intramuscular or subcutaneous, transdermal or oral. Various preparations available are testosterone enanthate or undecanoate, or there are testosterone pellets available for subcutaneous insertion, or testosterone patch for transdermal application, or testosterone gel, and oral preparation include testosterone undecanoate. First pass hepatic metabolism of testosterone is highly efficient. So, bioavailability of ingested preparation is poor. Doses of systemic testosterone can be titrated against symptoms. Circulating testosterone levels may provide only rough guide to dosage because they may be highly variable. Testosterone therapy can aggravate prostatic carcinoma. Prostate-specific antigen should be measured before commencing testosterone therapy in men older than 50 years and monitored annually thereafter. Hemoglobin concentration should also be monitored in older men, as androgen replacement can cause polycythemia. Testosterone replacement inhibits spermatogenesis. So, in this class, we have seen about reproductive system, that is functional anatomy, physiology, and the presentations of disorders of reproductive system. It can be presented in the form of delayed puberty, precocious puberty, or there may be amenorrhea or male hypogonadism. In the next class, we will see about gynecomastia, hirsutism, infertility, as well as Turner syndrome, Klinefelter syndrome. Okay, thank you.